But before I introduce our speakers, I do want to acknowledge the Juneteenth holiday yesterday, which is a federal and state holiday recognizing the emancipation of enslaved African Americans. And Juneteenth marks a date of major significance in American history and shows us that freedom and racial equality have always been a hard-fought battle for African Americans. And as public health advocates, and we really all are on this call, as public health advocates, it is a reminder that health equity should be applied to all of our efforts as a foundation of our work and really the integral part of what we do each day. In honor of Juneteenth, our tobacco control team recommits to the work that we're already doing to integrate health equity into all of our cessation and tobacco control programs and to protect all Virginians from the harms and risks of tobacco and nicotine products. So again, I just want to thank all of you for joining us in that commitment as we really celebrate and acknowledge Juneteenth this week. So thank you all. So now we will again thank Michael and Kyle for joining us. You all know before we start, we want to ask a question just to see where you are and how you're going to use this data. So how do you anticipate using the statewide data to make an impact in your community? And there are lots of ways: grant writing, support for your local programs, to help you identify priority populations, to help you prioritize community resources, to encourage your organization to become a Quit Now Virginia referral site, to advocate for a tobacco-free policy within your organization, to educate community about tobacco-related issues, to share with legislators, or something other. And if you do have something other, please add it to the chat, because we would love to hear how you are using this data. So many different ways. That's why I'm really excited about this webinar today. One more second to mark. Maybe you're going to mark them all. You definitely could. And let's see how you're using them. Yeah, so it's a wide range of how people use this data. I will share with you, this is probably the number one question that I get when I go into the community is what is the data? What is that showing? Because really, whatever we do with our programs and initiatives, the data should kind of lead us, right? It should be our story of how we're getting there. So definitely, this is great to see that you're all right in the smack dead of doing all of these things. Wonderful. So I'm going to introduce our wonderful speakers, and I think they're both probably not new to most of you on the call today. Kyle Jerome is the Tobacco Control Program epidemiologist and evaluator with the Virginia Department of Health. He served as a vector-borne disease epidemiologist with Virginia Department of Health for almost 5 years within the Division of Surveillance and Investigation, monitoring tick, mosquito, and other arthropod-related illness in Virginia. Kyle knows I love this piece about him. When not working, Kyle enjoys spending time with his wife and 2 daughters, landscaping, trying new breweries, and playing fantasy football, something I did not know about him. So welcome, Kyle. And we also have Michael Parsons, who is a wonderful partner with the Virginia Tobacco Control Program with his organization, has done really amazing work throughout Virginia in all of the regions, because he's the director of programs for the Virginia Foundation for Healthy Youth, and he's been there since 2020. At the foundation, Michael oversees 4 regional grant administrators, each whom administer a caseload of youth tobacco use prevention and childhood obesity prevention grantees across the state of Virginia. And many on this call probably get one of those grants from the foundation. Before coming to the foundation, Michael spent more than a decade working at community nonprofit organizations, specializing in practical program assessment, evaluation, and data-driven decision-making. So Michael and Kyle, thank you so much for joining us today. I'm going to turn it over to Kyle to get started.
All righty. Good morning, everybody. See if I can share my screen. All right, can we see that?
Yes, we can. Thank you, Kyle.
Awesome, awesome. So good morning, everyone. We get to talk about another tobacco-free Tuesday today. I've been on the sidelines for most of these, as this is, my program who's kind of hosting this forum. And I'm happy to be able to be, in the mix today and be truly a part of it and pick up the mic and talk about some statistics with you all today. So with that, I think we can go ahead and get started. And again, happy belated Father's Day to any dads out there listening. So I think it'd be appropriate to start with where this data comes from, build a little foundation here. So our data comes from the Behavioral Risk Factor Surveillance System, and this is the source of all the data we'll be discussing today. This survey or questionnaire is administered annually, January through December, across the U.S. to adults age 18 years and older via random digit dialing of landlines and cell phones. BRFIS participants make up the survey sample size, which is used to estimate the total likely occurrence of a given parameter across a defined area. The survey is composed of core, optional, and state-added questions, which I'll speak to a little more in the coming slides. Some of you may already be familiar with the timeline of BRFIS's data availability, but it typically lags 10 or more months behind the year the survey was administered. So for example, 2022 data collection was completed in December of this past year, but initial analysis of the data set cannot be performed until about fall of 2023 at the earliest. So the adult tobacco survey is a piece of the larger BRFIS questionnaire. More specifically, it is a subset of questions speaking directly to tobacco and nicotine use, asked only of a percentage of the total BRFIS participants, typically in years past about 50%. However, in 2023, VDH was approved by our state BRFIS contractor to oversample at a rate of 90%. So in other words, 9 out of 10 BRFIS participants will be asked the ATS formulated questions. An important note is that the ATS is administered and included in the BRFIS questionnaire only every odd year. So 2019 was the first year the adult tobacco survey was administered. 2021 is the last year for which we have a complete data set, and 2023 collection is currently ongoing. Another component of the BRFIS survey are a variety of pre-developed optional modules. These are additional specialized questions created by the CDC that can be selected and paid for by states and asked of their BRFIS participants. Some examples of optional modules include tobacco cessation, other tobacco products, ACEs or adverse childhood experiences, social determinants and health equity, and many more, all of which can be administered with the help of some additional funds, that's a big piece, and support from leadership. Each additional question carries about a $6,000 price tag. Some relatively exciting news, though, is that Virginia has been selected and awarded funds by the CDC's Office on Smoking and Health with the National Center for Chronic Disease and Health Promotion to administer a new optional module, Other Tobacco Use, as part of the 2024 BRFIS. This optional module's goal is to collect more information revolving around menthol use. So now that we have the background stuff cleared up and we know where our data comes from, I think we're ready to dive into the deep end and get working through some of these statistics. So first, let's take a look at some rates regarding individuals who smoke cigarettes. The current smoker variable is defined as an adult over the age of 18 who has smoked at least 100 cigarettes in their lifetime and who currently smokes on at least some days. It's important to clarify that this data element is used only to define prevalence of individuals who smoke cigarettes. This variable is typically chosen as the poster child, if you will, and is the one most often used to determine the burden of tobacco and nicotine on a given population. Virginia has continued in the right direction, falling from 16.4% in 2017 to 12.4% in 2021, while also remaining below the national average each of these 5 years. In 2021, the national average of people who were considered a current smoker was 14.4%. The graph on this slide also shows the stark contrast in cigarette smoking behavior when comparing the Northern Health region of Virginia, which recorded the lowest reported population of cigarette smokers, rates remaining below 10% over the 5-year period, and the Southwestern Health region, whose population had just begun to sink below the 20% mark, with a recorded 19.3% in 2021. Digging a little deeper into the socioeconomics of cigarette smoking, first looking at education level, we can see individuals who have graduated college remained infrequent consumers of cigarettes between 2017 and 2021, declining another 2% over that time to just 4.2%. Those who did not complete high school or equivalent education showed decline in 2018 and 2019 to below 25%, but climbed again in 2021 to just back over the 30% mark. Income level is another indicator among current smokers that highlights a significant disparity among those with lesser resources. Individuals who made $25,000 or less were more than twice as likely to be a current smoker when compared to individuals bringing in $50,000 or more, each of the 5 years reported. Helping to further define the impacts of tobacco and nicotine on Virginians are the age and gender demographics. From 2017 to 2021, each of the 6 age categories reported out in BFHY showed a decrease in the percent of people smoking cigarettes. And I'm very happy to report that the 2 age groups showing the most significant improvement were the 18 to 24-year-olds and the 25 to 34-year-olds, both categories down more than 7% over the time period presented. The age groups who showed the least amount of change over the 5-year period were the 55 to 64-year-olds, as well as the folks aged 65 and over, both of which remain pretty stable. And I do want to take a quick second to provide an important statistical acknowledgement denoted by an asterisk you see throughout this presentation. The asterisk is being used to underscore particular statistics where the sample size did not meet VDH's Population Health Surveys team's threshold for unstable rates. Its main purpose is to caution anyone in regards to its interpretation before putting it to use. The smaller the sample size, the more unstable the rate, which is one of the main reasons we're so ecstatic to be oversampling in 2023. I just wanted to make sure I pointed that out before continuing on, as this slide was the first an asterisk appears. And moving along, when comparing rates by gender, again, we saw a decrease in cigarette smoking between 2017 and 2021, continuing the trend of individuals moving on from traditional cigarette smoking. Another exciting stat to report is that 2021 marked the first year both males and females recorded a current smoker percentage below 15%. Switching gears from cigarette smoking to vaping and e-cigarette use, the current e-cigarette user variable is derived from the BFHY question, do you now use e-cigarettes or other electronic vaping products every day, some days, or not at all? And tallies those who responded yes to every day or some days. Overall, e-cigarette use is trending in the wrong direction, with all but the Southwestern Health Region increasing e-cigarette and vaping use rates from 2017 to 2021. The Northern Health Region retained its status as the jurisdiction with the lowest e-cigarette use rate, but was also the only health region to exhibit an increase across each year from 2017 to 2021. Teasing apart some of the socioeconomic data regarding e-cigarettes and vaping, and again looking at education level, we see that people across all education levels have shown an increase in vaping and e-cigarette use between 2017 and 2021. Somewhat surprisingly, individuals who did not complete a high school education or equivalent have shown the smallest increase, only up slightly from 5.3% in 2017 to 5.9% in 2021. However, you might recall this group made up the majority of the cigarette smokers. Both the high school, GED, and some college categories increased by nearly 3% over the 5-year period. Similar to trends seen in e-cigarette use across all education levels, e-cigarette use rates also increased within each of the income categories. The income level category that showed the greatest increase from 2017 to 2021 was among individuals making between $25,000 and $35,000, rising from 6.5% to 9.5%. Checking in on e-cigarette use rates by age, we can see a pretty clear story unfolding in the chart shown that represents the transition from more traditional cigarette smoking to an era of vaping. It further emphasizes the impacts of big tobacco's marketing tactics and how that has influenced youth nicotine use behavior. Notably, the 25 to 34-year-old age group increased from 8.4% in 2017 to 13% in 2021, while the 18 to 24-year-olds recorded an e-cigarette use rate of 18.5% in 2021, up 7.7% since 2017. Clearly, more work is needed to curb the increasing number of young people who are choosing to partake in e-cigarette use and vaping. Transitioning to gender demographics, male e-cigarette usage from 2017 to 2021 was significantly more prevalent when compared to women. In 2019, male e-cigarette users nearly doubled the amount of female e-cigarette users at a rate of 8.3% to just 4.6%. Both males and females exhibited an increase of more than 1.5% from 2017 to 2021. Moving along to smokeless tobacco and smokeless tobacco users, this variable is derived from the Burfus question asking participants, do you currently use chewing tobacco, snuff, or snus every day, some days, or not at all? And is tallied by those who answer yes to either every day or some days. Smokeless tobacco use is another area where Virginia is on the decline, steadily falling each year from a 4% overall use rate in 2017 to 3.4% in 2021. And although the Southwest Health Region maintains the highest smokeless tobacco use rates, they did experience their most significant decline from 2020 to 2021, decreasing usage by almost a whole percentage point. Unfortunately, I won't be able to break down smokeless tobacco into its demographics, as there is a pretty small sample size once the statistics get more granular, which makes it difficult to make accurate claims. So now, as part of this presentation, I'm super excited to announce the development of a new variable. With assistance from the VDH Population Health Surveys team and input from a few member states of the Tobacco Control Network, the VDH Tobacco Control Program has successfully created a nicotine use variable. There were some challenges along the way, but with some fine tuning, I think we have a valuable new data element to analyze and apply to our work. This variable combines the yes responses from the following Burfus and ATS variables: current smoker, current e-cigarette user, current smokeless user, as well as other tobacco products user. This variable only includes 2019 and 2021 data in line with the years the adult tobacco survey has been administered. This new data element will be beneficial to tobacco control in a multitude of ways, and the idea behind developing the nicotine use variable is to get a better overarching picture of the true and complete burden nicotine use has on our communities. It also serves us well in that the sample size for most of the reporting parameters is substantial enough to enable us to make more accurate conclusions by utilizing more stable and reliable rates. Previously, I had stated that the current smoker variable is the first statistic used to serve as the defining variable for tobacco's impact on a community. My intentions are to hopefully phase out the use of the current smoker variable in this fashion and replace it with the nicotine use variable. So with that, we can get our first look at the nicotine use variable. And in 2019 and 2021, Virginia recorded a nicotine use rate of more than 15%. Even more astounding is that in 2021, our most current data, nearly 1 in 5 Virginians were considered current consumers of nicotine in some form or fashion at 18.8%. In the Southwest Health Region specifically, that number grew to more than a quarter of the population who reported using nicotine. The Northern Health Region was the only health region to exhibit a decrease from 2019 to 2021, while all other health regions increased nicotine use rates by more than a full percentage point. And diving into the socioeconomic statistics of nicotine use, those who sought or completed post-high school education showed little to no change in their nicotine use levels from 2019 to 2021, with college graduates actually exhibiting a modest decline of just 0.2%. Conversely, individuals who did not complete high school or equivalent experienced a significant leap in nicotine use, increasing from 25.3% in 2019 to 33.7% in 2021. The high school GED category also showed an increase, albeit to a much lesser extent than those who did not complete high school, rising by 1.8% between 2019 and 2021. Nicotine use among all tracked income levels increased by at least 1% from 2019 to 2021, with the average change settling in at 4%. The income level that experienced the greatest increase were those individuals making between $25,000 and $35,000, rising from 21% to nearly 30%. Sustaining a trend, individuals making $50,000 or more were the least likely group to consume nicotine of any type. Some more demographics regarding consumers of nicotine. Again, the most concerning takeaway from the analysis looking at nicotine use by age is the increase among young adults aged 18 to 24. In 2019, people aged 18 to 24 recorded the second lowest usage rate, trailing only the 65 and older aged individuals. But in 2021, this group saw a more than 5.5% increase in nicotine usage rate, vaulting them to the third highest, with only the 25 to 34 and 35 to 44-year-olds recording narrowly higher rates. Moving along to the gender analysis, and a fact I found surprising, when accounting for all forms of nicotine consumption collected within the adult tobacco survey, it was the females who showed a greater increase from 2019 to 2021, even if only slightly. Women marked a 1.1% increase, while males recorded a 0.7% increase. With that said, males still account for a much greater percentage of nicotine users overall, at approximately 226 per 1,000 males to just 151 per 1,000 females. And with that, I'd like to just, close it out, provide some acknowledgments. So a big thank you to the Population Health Surveys team, and particularly Rebecca Sultana, my own division, and the Prevention and Health Promotion EPI Manager, Aaron Austin. Also appreciate the review of upper leadership here in the Office of Family Health Services. And thank you to the Tobacco Control Program and the rest of my team for giving me the opportunity to present with you all this morning. And with that, I think my last slide yet is a contact info. So I'm very open and informal in a lot of ways, in that you can reach me any way you want, anytime, really, email, phone. This particular link here that I believe will be shared out in the chat is to submit data requests, not just tobacco data requests, but anything within the Division of Population Health Data, so chronic disease, maternal and child health stuff, but certainly any tobacco related requests will come right to me. So thanks again. And I think with that, I'm going to pass it over to Michael, who can go over some of the youth data with you all.
Thank you, Kyle. I'm going to attempt to share my screen. All right, can everybody see my screen?
Yes, we can see it.
Awesome. Kyle, thank you for that. So Kyle just gave a wonderful presentation about tobacco and nicotine use among adults beginning at age 18. I'm going to give you the first part of that story. So how are young people up to age 18 doing in Virginia right now? The best way that we have to present those data are through the Virginia Youth Survey. You may have also heard it called the YRBS, or the Youth Risk Behavior Survey. This survey is funded by the Centers for Disease Control in Virginia, and there are equivalent surveys all across the country. It's a partnership between Virginia Department of Health, the Virginia Foundation for Healthy Youth, and the Virginia Department of Education here in Virginia. A couple really useful qualities about the survey. Because there are equivalent surveys given all across the country, we can both provide representative information about Virginia's youth. We can also benchmark that against national youth, which makes it really useful. The purpose of the survey is to monitor health-related behaviors of young people that contribute to leading causes of death, disability, and social problems. The survey is given every other year on odd-numbered years. So the most recent data I have are from 2021, and we're gearing up for the 2023 survey now. Kyle mentioned a lag in analysis. That is certainly the case for these data. It took us a very long time to get those 2021 data analyzed. And so when we give the surveys in 2023, we're hoping to have less of a lag time, but we won't get the results right away. Some really great things about the VYS are that we can break down these really rich data sets by demographics, things like race or ethnicity, or gender, or even VFHY regions. So we split the state up into 4 regions. It doesn't map exactly onto the regions you just saw, but they're pretty close. And that means that we can really drill down into any particular question. Another thing I like about the survey is that they do a really good job of asking the question in the same way every other year, which means that we can look at trends, both trends across the state and trends by region. And I'm always much more comfortable trying to use data and draw conclusions when we have many years of information to go by, as opposed to just a point in time. So I'm not going to try to give you an exhaustive deep dive into the survey. I'm going to show you how we've used the survey recently at the foundation. And of course, we're here to answer questions or to present the data in other ways if it's useful to you. So I think before we actually look at the data, the VYS describes youth substance use in a number of different ways. I want to just give you a sense of different levels of substance use. One particular way is, did a young person try a substance at all before the age of 13? So of course, if a person did it at age 10, they would also always answer yes to that question. The other 2 are frequently and daily. So it asks the young person, looking back on the last 30 days, did you use that substance on 20 or more days? And then again, did you use that substance on every single day in the past 30 days? For almost every substance use question for kids, that number is vanishingly small. There are very, very few young people using a substance 20 out of 30 days or 30 out of 30 days. So we very rarely report that. It's always less than 1%. The one that we nearly always use is current use. And so it asks young people, have you used a particular substance on at least one day during the past 30? And we nearly always use that because it's really useful to try to figure out change over time. And so all the data I present today are going to be current use among Virginia high school students, and they should be representative samples. So we're going to talk about tobacco and nicotine products. I think it's important to benchmark those against other substances that young people might use. So I went through the past decade, and I just plotted the major substances that young people in high school might use, and I put them all on a graph for you. If we didn't have that question, then there won't be data for it. If we ask the question, you'll see a point and a line. In terms of broad trends, you'll see that we asked about alcohol, vaping, marijuana, prescription pill abuse, cigarettes, cocaine, methamphetamines. A few things to know. Vaping is not a drug, it's a mechanism. And so it's a little bit of apples to oranges, but most young people who are vaping are vaping nicotine, but they could certainly be vaping marijuana or something else. So just to be aware of that. In terms of broad trends, as you all know, most substance use has gone in the right direction over the long period of time that we've measured. So alcohol has been going down for many years. Obviously, cigarettes, traditional cigarettes have cratered. So you can see in 2011, about 15% of high school students smoked in the past 30 days, and that's fallen way down to 2.8%, which is really great to hear. Cocaine, methamphetamine, marijuana are all down over the time period that we've measured them. There are 2 substances that have bucked this trend. One is prescription pill abuse, which is plateaued. It hasn't gotten significantly better or worse since 2017. And the other is vaping, which is also plateaued. It hasn't gotten significantly better or worse since 2015. You can see that it's a jagged line for vaping. So where the fall to 11.8% is a little bit suspicious. We think maybe it has something to do with the question that was asked. But in terms of broad trends, it's right around where it was in 2015. And this broadly matches national statistics as well. Virginia tends to be a little bit lower than the national rate for most substances, and then tobacco and nicotine are no exception. You can also break apart any particular question by demographics. Kyle mentioned that he liked to have a indicator that really combined multiple products, which is probably more useful. So this question is the percentage of high school students who currently smoke cigarettes, cigars, smokeless tobacco, or vapes. It's a really useful question to try to capture as much substance use as you can to try to figure out trends. This is a breakdown of gender. Male is blue and female is orange. And this is a trend that we've seen here in Virginia, but also across the country, that very recently there has been an increase or a flipping of male-female use. And that may be connected to the large-scale national trends around female depression, anxiety, and substance use. So we're seeing that here in Virginia, and we're certainly seeing it across the country. And it's something that we really want to keep an eye on going forward. And we really want to see in 2023, after the pandemic, is it going to keep that same trend, or is it going to revert to its traditional role where young men typically use substances at a slightly higher rate than young women? We can also break it down by race or ethnicity. This is the very same question, but we just pulled apart self-reported race or ethnicity categories. This also broadly matches the national data, where self-identified Asian students are far less likely to use nicotine and tobacco products, whereas white students are much more likely to use it than their peers. And you can see that they all sort of follow each other in the trend data, but there's not a lot of change in position there. The survey also asks young people to self-identify if they're heterosexual, gay, lesbian, or bisexual, or questioning. And some of the substances, there's no substantive difference between different categories, but there's a few where there's a clear difference between those who identify as heterosexual and those who identify as gay, lesbian, or bisexual. That same question that we've been looking at over the past few slides becomes very evident that there's a huge discrepancy between these two groups. So about 14.4% of heterosexual high school students answered yes to these questions versus 23.7% of gay, lesbian, or bisexual students. It's a huge jump. And it's something that we really want to focus on to make sure that we're responding to the actual expressed need of Virginia students. It's not on here, but it's also true that those who identify as gay, lesbian, or bisexual are much more likely to begin using tobacco products before the age of 13 when compared to their peers who are heterosexual. Something else that maybe we don't think about often is the experience of young people just in the school day. This is sort of an interesting question. It asks young people to describe their typical grades in school, A's, B's, C's, or D's, and F's. And there's a sort of a staggering difference between those young people who say that they get mostly A's and B's versus those who really struggle in school. You could imagine a number of reasons for this, but it's for sure, it's a massive difference. So those who say that they get mostly D's and F's, about 40% of them use a substance that has nicotine in it, versus 12.6% who get A's. That's like a staggering difference in group trends and usage rates. Also something that we want to keep an eye on at the foundation. We mentioned before that since 2019, we can break apart any question by geographic region. So our regions won't match up exactly with some other regions that state agencies use, but it gives you a sense of where the North, the Southeast, the Southwest, and Central are. So any question that we look at, we also want to drill down and get a sense for how that region is trending as well. If you look here, this is that very same question, but the red line is statewide high school use. We've broken apart each region. This pretty clearly maps on to what Kyle showed for adults, where consistently across the board, the North region has the lowest tobacco and nicotine substance use. In the Southwest, despite having a relatively low population, has a much higher percentage of that population using tobacco or nicotine products. And we currently have Central and Southeast somewhere in the middle between those two. This is the last part I want to show you. This has not been released. We partnered with a data analysis firm just to provide an extra level of analysis. And we asked them to provide a propensity score. So taking into consideration all of the potential demographic categories, which combination of demographics is most likely to predict current tobacco or nicotine use? A different way to think about using the data. Some of these are obvious, where older grades are more likely to use, which we knew. But we also asked them to plot things like, getting mostly A's or B's, and also self-identified poor mental health. There was a proxy question that correlates with negative mental health. And you can see that these are all the combinations of categories that have a very high probability of current tobacco use. And I was really struck by young people who have expressed that they have poor mental health are far, far more likely to use tobacco or nicotine products. And if you combine that with those receiving poor grades, those who self-identify as gay, lesbian, or bisexual, the percentage goes dramatically up. You can see the actual probability or propensity score on the far right. It's a different way of trying to use data to figure out which specific populations are most at need of assistance. So this is a pretty quick tour of how we've used the data so far. But like I said, we can keep peeling back the layers and going a little bit deeper and a little bit deeper to try to figure out how we could best support young people across the state to either quit using tobacco or nicotine or to never start in the first place. And I will also put my email address in the Q&A box in case anybody has any follow-up questions. I think I'm going to turn it back over to Nicole.
Yes, thank you, Michael and Kyle, for all of that data information. That was a lot to take in. So I didn't chat too much in the chat because I was just trying to take everything in. But from both of yours, it's just very interesting to see like the socioeconomic versus the trends in the different regions. And it's just so interesting because it's like not surprising, but there are some parts that were surprising. I don't know. I was just really enamored by what you guys are saying. 'Cause I was like, oh my gosh, I never really get too much into data like this. So it was just very interesting. Anyways, so the first question we have from the chat is for Kyle today, and it kind of came in during the registration as well. So there's two. So Kyle, I'm going to read you the question that came in when people registered, and then in the chat today too, because they're both very similar. Let me find it. So it is, are you able to speak to the increasing incidences of young adults utilizing ENDS products for weight control purposes? So Michael, you can always add on to this too. So in the chat today, someone asked a similar question was, did you have an opportunity to review data regarding the link between increased use of e-cigarettes in correlation with weight concerns, especially among females and sexual/gender minorities? So Kyle, if you want to answer that first, and then Michael,
Sure.
if you want to add anything else.
Sure. First, thank you for that question. And I have personally not had or have not looked at that particular association between folks using ENDS and whether or not there's a weight control, a piece of that. But you bringing up that question and, knowing that may be something needed in our communities to look into and analyze further. We do have other folks here within our division at the Virginia Department of Health who look at healthy nutrition and obesity and things like that, who maybe I could collaborate with, and we could do, produce a little bit of an analysis looking further at that. But no, personally, I have not seen or heard of folks, turning to ENDS products for weight control. I have not, but thank you for that question.
Michael, do you have anything else to add to that?
I don't think so. I also don't have any specific information about that. Obviously, people have used, cigarettes for that, but I don't know about vaping in particular.
Yeah, no worries. And I think it with your last slide, Michael, it kind of linked it together, because you really talked about youth who identify with negative mental health. And so, with weight or, body image issues, that can kind of coincide together. So it was just an interesting question that I don't think we ask, but maybe it is a need. And what Kyle said, we can collaborate with another part of VDH to work on that too. So great question. I thought it was interesting. I wanted to bring that to light.
And just to add to the mental health thing, for a long time, if somebody was receiving psychiatric treatment, then tobacco was used to actually help them get off other things that manage stress, which we know is unhealthy. So there's a long history of people using cigarettes who have other sort of acute mental health needs, which is replacing sort of one unhealthy behavior with another. And that's something that I think we should also take a look at.
Definitely, yes. I know with VDH, we've been trying to work with behavioral health, because some people say, tobacco is like the lesser of the evils, but it goes to show, like, if you quit both, drinking or any other substance abuse at the same time as smoking, you're more likely to stay quit. So that's a great point as well. And we had another question in the chat from Michael. I remember you had a slide about like heterosexual, gay, lesbian, or bisexual, and like the difference in tobacco use. And someone asked, do you know if there's a question about the transgender population?
If I recall, for 2021, it was gay, lesbian, bisexual. There's a category about questioning as well. I can't recall, and maybe somebody from VDH could help, if in 2023 they're adding an additional question. I feel like there was a question about that, but I can't remember. I haven't seen a breakdown by it.
Okay, no worries. Yeah, that's something that I think we can start thinking about, in data to really include all the populations. So that's interesting too. So we'll have to check that out and get back to you on that answer for sure. Another question I thought was interesting, this is for both of you. Someone asked, is there any recommendations on how local data collection can also include qualitative data and stories? As with Tobacco Free Tuesday on every November for Great American Smokeout, we include, a panelist of people, and they share their quit journey, because a lot of those stories, that qualitative data really makes an impact, and a lot of our surveys are more quantitative data. Do you foresee in the future maybe there will be an add-on for a qualitative section, or do you guys see that? Kyle, go ahead. I see you.
Yeah, I'll take a shot at this. I would say that qualitative data is great. Like, that's awesome to get to dig into and analyze. But my initial thoughts when I see this question is, BRFIS is a large, national survey. So attempting, and it takes a lot of people's time as it is, getting hit with tons of questions. So it absolutely would be interesting to tie in or, follow up with folks who may have answered the survey, and just come back with them if they've answered pieces of the adult tobacco survey, and get it like that story about them, and maybe they've tried quitting in the past, or maybe an opportunity to connect them with our Quit Now Virginia services or something like that. I think would be super beneficial, but I think that's a tall task. Our funding, is limited in a lot of ways, with our contractor who does all the calls and reaches out to folks. It's really put on by the CDC. So I think this is something that we could take up the chain, and try and work it in, because there is value there. I think that we could, tease out of it and make stronger connections with the data and with what people are truly saying and thinking. I do think it would be difficult, though. I will say that, just with the wide and just vastness of BRFIS and Yerbis as well. But I'll let Michael, maybe he has some thoughts on that as well.
No, I agree with Kyle. I think that it's powerful to pair data with personal stories. I think that that's always going to be the case. However, if you want a very high quality survey, you have to give up some of the more, qualitative aspects of it. You don't get to pick who you survey. It has to have a randomized portion to it, and you can't, there's not a lot of leeway in how you ask the questions because you don't want to lose the richness of asking the same question the same way each time. So it's, the more scientific it is, the more strict it is. But you should, I think if you're trying to convince somebody of something, you should absolutely try to pair that hard data with the actual stories of what somebody experiences on the ground, why they quit, what's the impact of tobacco or nicotine. And those don't have to be directly connected. You don't have to follow up with somebody who took the survey to get quotes or stories from people who are impacted by drugs.
Very true. And I was just thinking about there is I work with EVMS kind of a lot, and there is a group who really wanted to know how adults their experience with youth and using e-cigarettes. So to get that qualitative stories, they've done either focus groups or one-on-one kind of phone calls or interviews or chats to get that qualitative data too. So that's an idea for local health departments. If you know someone who want to share their story, you can do that too. So just an idea. But yeah, I think qualitative data and the stories really do make an impact. They put kind of a face to those numbers, right? And so I really appreciate it. And to kind of go off of, adding qualitative data, there's a question mostly for Michael. They asked how often this survey is administered, and I know you said every other year, but were there any new questions, in the past year or that are coming up that you'd like to kind of talk about as well?
I haven't seen the full list, but there are going to be a few more questions around opioids. You notice that I presented on prescription pill abuse as a very specific measure, but there's been a pretty serious increase in opioids and fentanyl deaths in Virginia, but also across the country. So there should be more information about that coming. And I have not seen the complete list of new questions, but like Kyle mentioned, it's a difficult task to add a question to a survey. And, to expect a young person, there's always more questions we want to add and add and add. But at a certain point, you have to limit the size of a survey so that young people or adults don't get frustrated and start Christmas treeing or skipping over questions.
Definitely, good point. All right, we have two more questions that came in the chat, so I'll try to ask them if we have time for both. The first one is there a way, is there a way to parse out those who have discontinued nicotine use, young and older individuals, and then perhaps what helped them change their behavior? So I guess, is there a question in either survey, if you've quit, and to answer, what has helped them quit? That's a good question.
We could probably do I haven't thought about that.
Yeah.
It's a messy way to do it. We could answer all those who did it before the age of 13, who said yes, of those who have said no to every other drug question. That's a pretty, I would need somebody smarter than me to figure out if that's even useful. But that's all I could think of as a proxy for quitting. So it's yes, it's a proxy, but you could imagine a lot wrong with doing it that way.
Yeah.
And I'll shoot for my end. As far as Burfus is concerned, they do ask tobacco cessation questions, and similar to some of the other questions. In the past 30 days, have you made an attempt? I think there's another one in the past 12 months. Have you made an attempt? And maybe a question about how long did that last? Those kind of things. So yes, there is an ability to reach back in there, but on the similar lines that Michael was just saying, that does provide, you got to code it out and really make sure that you're getting at the question that you're seeking to answer when you're doing so. But there is a specific, and it is an optional module, and I don't have offhand if that's one that Virginia has opted into as far as tobacco cessation. I believe in the past we have. I'm not sure about going forward. If that's going to be like a consistent one that we're using, but it is out there. So that's something also that we could look into. Thanks for that question.
Yeah, definitely. And Again, just to bring it back to our November Tobacco-Free Tuesdays, when we have the panelists of people who share their quit journey, I think it's important also for people to realize, everyone's journey is going to be different, and maybe a product that worked for you won't work for someone else, or, so it's just different. I always encourage people, it's going to be different for everyone, and some people can quit cold turkey and it's easy for them, and other people, it's just not. And it's very difficult, but continue working on it, and that they're capable of quitting for good. So one last question before we end from the chat. I think this is for Kyle. I'm curious about the changes noted in adult tobacco use by educational status. Any ideas, Kyle, on why those stark increases were noted for those with lower levels of education?
That's a great question. I mean, I think it's probably multifactorial, of course. But yeah, so I guess, yeah, we're speaking as folks, they just seem to hold on, as at least what this data was showing, that they hold on to the more traditional cigarette smoking and haven't maybe experimented with vaping and things. I know the Southwestern Health Region was one that kind of has the more traditional current cigarette smoking ongoing, as well as smokeless tobacco, and is not quite transitioned in the new era of vaping. But that's not to say that it hasn't reached there yet or anything, and that can't still make a change. As I wanted to say those numbers were going up, but I'd have to go back and look at my own data. But I don't have a simple answer for that. I think that's something we could, continue to analyze and maybe get more granular with it. I didn't do that, as I was stating, rates, become more unstable as the sample size drops. So the more granular, so if you're moving down from health district to the county level and things like that, the numbers get less and less, and we can depend on them less and less, or they're not as valuable or credible to us. But yeah, at the health region level, that's certainly what we're seeing, as folks who have not completed high school are continuing to smoke cigarettes and use traditional smokeless tobacco.
Yeah, and just to go off of that, if you also notice that the use of e-cigarettes is usually higher in high SES, or more affluent communities, or with higher levels of education, and that could be because the cost of e-cigarettes are usually a little higher, than combustible cigarettes. So you can kind of see that as well.
That's a great point, Nicole. Yeah, the price piece of it. Yeah.
And unfortunately, there's no question about income or SES for the youth survey. So there's not even really a good proxy question for it, which seems like, if I could add one thing, I mean, it's hard to collect because somebody might not know their income or their family, but if we could figure out how are, relatively affluent kids doing, which drugs are impacting them versus kids in poverty, I think that would be really useful information, but we currently lack it.
Definitely. Well, thank you everyone for all of our questions. I think all these topics really highlight, things that are important to all of us in the state, our local community partners, and this is really, really great data. So again, if you have any questions, definitely reach out to Michael or Kyle. They're very helpful. They're very quick on responding too. So, and we're all trying to work together to, if someone doesn't have it, we'll find someone who does have that answer. So I'll pass this on to Gina to kind of close us out for the day.
Thank you, Nicole, and thank you both, Michael and Kyle. Wonderful presentations. The big key that I took away from both of your presentations is we in the community and the state really need to look at the data and kind of focus our resources toward the different populations, right, that have those higher prevalence rates. And that's something that I know at the Tobacco Control Program, we're working very hard to do, but it's really, we can't just sweep across the whole state with one message. We need to really focus on those populations with the higher prevalence for tobacco use. So I thought both of your presentations really highlighted that, right? So great job. Thank you so much for joining us today. Please, if you're on the call, reach out to Michael and Kyle if you want further information, further data about how you can use it in your community, because I think it's very helpful. Of course, in our first question, all of those reasons why you can benefit from this data. And it's so many ways. So thank you again for joining our June Tobacco-Free Tuesday webinar. I hope you all will come back in July 18th, for a very special webinar. We know in Virginia recently, we now have 4 casinos that have opened up in different areas, and we're working really hard to get them to go smoke-free. None of them are smoke-free, so they allow smoking at each of the casinos. So July 18th, for our Tobacco-Free Tuesday webinar, we are excited to have the American Nonsmokers Rights joining us with their Cease Coalition that really focuses on the employees at these casinos. Join us to talk about how Virginia can really tackle this issue and how we can work with these casinos to go smoke-free. You know, I believe the law, Virginia law, allows them to allow smoking in the casinos, so we need to work at a local level to get them to voluntarily go smoke-free, and also at the statewide level to really advocate for why there needs to be change. So again, July 18th, mark that on your calendar at 10 o'clock. Everyone, thank you for joining us. Have an amazing begin to your summer this week. I hope some of you do see sunshine at least one day. I'm not sure about here, but at least one day I hope you see sunshine. It will warm up. It will be 95 soon, and we will be wanting it to be 70, right? So enjoy, have a wonderful week, and I will see you all in July. Bye.